All right, kicking off another episode of the Healthcare Growth Cycle podcast. And today we've got on CEO of VitalCare, Chance Basinger. So Chance and I connected earlier this year, or maybe it was late 2025. But you know, we've had quite a few telehealth founders on the Healthcare Growth Cycle podcast, and Chance brings a ton of expertise in the skilled nursing facility virtual care route. So I'm curious to learn about all that. I know I listened to your podcast, actually, one of your episodes, Chance, months ago now. But
Well, good for you for braving and listening through it.
It was, I found it really fascinating, and I got to learn more about all the craziness of skilled nursing facilities and all the different variables that make it a complex work environment, especially for the nursing staff. But before we get into that, I'd just like to kind of go through your background a little bit, everything from education into being a practitioner and then founding VitalCare. Just walk us through that journey a little bit.
Yeah. Great to be on, Christian. Thanks for keeping following up, and everyone's schedules are kind of crazy and it's been kind of a grind this year, but happy to talk through today. My journey's been a little bit non-linear. If you look back, I did undergrad and grad school and business focused entrepreneurship and then finance, and went directly into the health administration space, and ultimately landed in the post-acute space. So we talk about post-acute, it's anything after a patient's getting discharged from the hospital. So a nursing home, which we call SNFs, sort of skilled nursing facilities, to assisted living facilities, which we call ALFs. So sometimes I'll flip up and I'll say SNFs or I'll say ALFs. That's what I'm referring to. And then ultimately on the post-continuum of care, where then home health or hospice ultimately for some of these patients. But yeah, so I did some management of skilled nursing facilities, became a licensed administrator. Did that for a couple of different companies and different roles within those aspects, and just a really tough operating industry, tough margins, tough patients. Patients are getting sicker. They're getting pushed out of the hospital sooner and sooner. And so the acute level of a patient in a hospital is now actually kind of running over into the post-acute space. So patients in the nursing facilities are just getting sicker and sicker, and the operating environment is really tough. So always a hats off to the people who are still grinding in the nursing facility post-acute space. It's because it's just so tough. And because the operating margins are so thin, that means your staffing is like difficult, and you have one nurse to like 20 patients. And if you remember, that patient just 2 days ago had a nursing ratio of maybe 1 to 5. And tenth of like the complexity and difficulty, they're coming out of the hospital. Now you have one nurse taking care of like 20 of those patients. So I know like a nursing home sometimes gets a bad rap, being like an old folks home, or and I think a lot of maybe our parents or grandparents' generation remember them being kind of just a place you go to die, and they're kind of a depressing and sad place. And so that still gets kind of this like overt rap. But I did that for many years, and frankly got kind of burned out. You're just always on call 24/7 and just fielding so many different problems and complaints. And we'll probably get into it, but like the regulatory environment to practice and operate in a post-acute space is so hard. Even just from a clinician standpoint, it's not the same type of medicine that you practice in a hospital. Yeah, it's almost completely different medicine. The patients are more difficult. There's a lot more comorbidities, just complex nature of medicine. And so it just makes the operating environment so hard.
And is that complex nature just the type of medicine, or is there a lot of HIPAA compliant considerations with a post-acute care space that makes it extra complex?
Yeah, there's just so many operating complexities. I split it kind of in two paths. You have this administrative fork that's just so hard. You have HIPAA compliancy, like compliance issues. You have cybersecurity now that everyone's worried about. But also you have, because these operating environments in nursing facilities operating margins are so thin, you tend to have kind of lower grade EMR as well. So
Okay.
medical record systems that are kind of like rudimentary. They're catching up now. There's a couple of great EMRs popping up in the space, like Point Click Care and Matrix. Um, but really, this is like an industry that's just so siloed because
Yeah.
some of the bigger hospital systems have some big players like Epic and Cerner and others that are too big for this space because Epic and Cerner is kind of they try to be everything for everyone, but with that comes a heavy cost,
Yeah.
and so like being able to then transform that and make it usable in the post-acute space is so hard because of the cost, and they're built for larger health systems. So you have this space where really you only have like Point Click Care and Matrix who are really competing in the space, and then you have a kind of a smattering of others that are trying to catch up, but you still have this like difficulty in sharing patient information, getting the right information, and all of those things. So the administrative side of like operating in that environment is so difficult. Not to
Yeah.
mention they're federally funded, so you have Medicare, you have Medicaid, all of which have seen like drastic cuts the last couple of years,
Yeah.
delay in payments from Medicaid, and so again, just an administratively really difficult operating environment from a business perspective. But then the second fork there really is the clinical side of it. So these patients are elderly generally, have many comorbidities, meaning they have diabetes, they have congestive heart failure, they have like CAD, they've had different bypass surgeries, they're
Yeah.
on blood thinners for recent like AFib or previous strokes. And so there's just this generally like more complex care of patients, and that's why they're in a nursing facility. And so you just have really the complexity. And not to mention, most of the medications and the things we see are tested on like average, healthy, middle-aged people, and even lean more on side of middle-aged white males. And so the um, being able to then interpret that into now a population of elderly people and with comorbidities that weren't tested on the medications, treating a elderly or geriatric patient, which is kind of the formal name for that population, is not the same. So a medication that would impact a middle-aged person could have a negative impact on a geriatric patient. So
Um,
there's a lot more considerations in the space from a clinical standpoint, that you're not navigating in like younger, healthier people. And so that impacts elderly people too. Their kidneys are slower, their livers don't filter as great. And so that medication stays in their system longer or
yeah.
has different impacts. And now you're having impacts of like memory and balance and dehydration. All the things you're having to consider on even just a patient who has a fever now kind of like makes it a difficult kind of workup rather than a straightforward workup for a like a middle-aged like person.
Yeah.
So operating
Way.
to try to wrap up my like background here, like operating in that environment was already difficult from the administrative side, but I had no idea about the clinical side. And that was actually really frustrating to me. And I felt like I was like hobbled in a lot of ways because I was making, in essence, financial decisions that were having clinical impacts. So, like which medications, which like interventions, how much staff we were putting
Yeah.
in place. And so I was making financial decisions that were having clinical implications, and like that weighed on me like really heavy. And for a
Yeah.
long time, I had considered like, man, maybe I'll go back to nursing school. I'd already had like a bachelor's degree and a master's degree, so I was like, oh man, that just doesn't seem like very smart. Though hats off to nurses and the work they do. And we were like, maybe I'll go to med school and started prepping for that. And then I'm like, oh man, that's like a 12-year life sentence.
Yeah.
Um, and I was like, man, I had two little kids and a mortgage. And so it didn't really seem economical. And ultimately landed on PA school. And so took some courses, started working nights and weekends in a local ER, children's ER actually,
Wow.
just to get some clinical hours, and got lucky and applied and got into PA school. And so ultimately went from administrative, got into PA school, became a clinician, loved
Wow.
it. Wouldn't do it again, but like loved the experience. And then kind of be more torturous. I then applied for a advanced practitioner fellowship where I did a surgical critical care trauma fellowship
Wow.
with a local health system, and that was a year-long, 80-hour week, kind of grueling process where I was stuck in an ICU for training. And but alongside that, I dabbled still back in the nursing home world because I would take contracts where I could be the rounding clinician, helping taking care of patients in a nursing facility. So
Wow.
really came just kind of full circle for me that I just kind of stayed in the space, but the space, like I said, was so difficult, but I had a unique kind of perspective because I now had worked on the administrative side and then had the luxury in my life, because I know not all people do, to go back to school and then train to be a clinician. So then
Yeah.
being the other side of kind of the operations on the clinical side. So
That's amazing. Yeah. And what then were some of the pain points that you saw differently as a clinician in home care skilled nursing facilities? Like, I'm just curious.
yeah, I think there's always this like, I don't know, cool like discussion about like admin's always at odds with the clinical team. And so like bridging that gap was like a lot easier because I understood the administrative pain points like margins and like reporting, and they have people to report to and paying their staff. And so I understood the difficulty, but that I could then kind of speak that language and say, hey,
Yeah.
yeah, if we do the quality care here, if we're able to do this, if we limit this or do this, it's actually going to have a really good ROI on your end. And so was able to take my clinical knowledge and essentially interpret that in for the business folks
Yeah.
who just speak a completely different language. And then vice versa, speak to the clinicians and be like, hey, this is why we're doing it, because we need this and this and this. And the things that we're leaving off the table in terms of billing and capturing, if we just did that, then we could have all those other things that we're wanting. So it was kind of a fun bridge for me to be able to generally speak. And
Yeah.
frankly, those clinicians are not always great business people. They think kind of patient first, clinical first, which is great. But they don't necessarily have that business mind of like ROI and money and what does that mean? Because they
Yeah.
just want to take care of the patient. So, um,
Yeah.
so the problem there was like really is just that communication and helping each other just understand the language that each were speaking.
Yeah. No, that's great. I can draw parallels from being like a marketer to an engineer or like a product marketer to an engineer. The product
Yeah,
marketer is always the
totally.
bridge to that business.
Just
Yeah. I mean,
different
so it's like the
languages,
same.
all trying to
Yeah.
do the same thing, but just
Yeah.
different languages. Yeah.
Yeah. Yeah. No, that's really cool. And as far as Vital Care goes, what was the inspiration behind that? There had to have been like what was like maybe one or two specific pain points that you were facing with this unique, really rare perspective being a practitioner as well as more of the business admin side of the house. So what was kind of the light bulb moment that went off for
Yeah.
founding that company?
No, good question. And I wish I could say it started out altruistically, that I wanted to like help out more people and make a bigger impact. And though that has come, it wasn't necessarily the impetus.
Sure.
I was like quickly falling back into this trap that I left the administrative side, that I was on call all the time. I could like slowly see some of those like getting burned out, creeping things coming into my life again. And I was like,
Yeah.
man, I just did a complete pivot to try to protect against this. And so one of those burdens really is just after hours calls. So as administrator, you get those on the business side, not as much, especially because generally have a DON who's like awesome and they have the really hardest job in the building, or nurses that are competent. But when you were the clinical one, making the clinical decisions, like a nurse can't start giving like Tylenol without a provider order. So
Okay.
a lot of times they're handcuffed too, in that they're needing to reach out to a provider pretty consistently for help. And so then I was getting on call again for 24/7, and I was like, man, I just kind of flipped the boat here and was still being on call and wasn't getting paid any additional money for that. So I was like, man, this was dumb. I doing the same thing, expecting different results, which is insanity that we always hear. And so
Yeah.
really just started me on a journey as like there has to be a way to make this better because I'd be getting calls about I'd be covering different buildings that I wasn't the main provider for a clinician, getting calls on patients I didn't know, all hours of the night. Ultimately, I was like kind of making sure to protect myself. So I'd be sending patients to the ER just because I was unsure, but I also wasn't getting any more like revenue or paid additional amount money to do this. And so I was like, hey, time out. There has to be some sort of way to like make all these problem points of like knowing who the patients were that I was speaking with and then capturing some if I was going to do it, I wanted to get paid for it. Um,
Hmm.
and so really just led me on a journey of like we trialed like 30 or 40 different telehealth platforms. And none we couldn't quite make any of them work in the post-acute space.
Okay.
And part of the user case reason there is like generally these patients are in bed, have comorbidities, they have maybe some like mental like incapacities or dementia or any of those types of things. And so the traditional telehealth model was, man, I'm going to log on to this telehealth platform. I need to put in some patient information, maybe my insurance. I need to,
Yeah.
and then it'll send you a text or an email to make an appointment. But I need to see a doctor right now. And so really just we couldn't find a platform that like just fit. And so we were like, man, well, why don't we just let's see if we can make this ourselves? And kind of shopped around for like different dev shops and none of them really wanted to operate in the healthcare space because HIPAA and all the compliance difficulties and really got lucky and landed on just a programmer who just got out of a Y Combinator situation and was aware of kind of the build up startup space and was
Yeah.
like, hey, do you think you can do this? And he hadn't really worked in healthcare, but he had an uncle who worked in healthcare and was like, hey, let's do it. I don't know if he at the time knew exactly what he was getting into.
Oh
And if
yeah.
he knew now if he would do it again, I don't know.
I don't know if
Uh,
any engineer does when they
yeah.
start. Yeah.
And so, but like totally dove in and like understood and started to understand kind of this like point of like, man, there has to be a way to get these patients who are really, really sick in contact with a provider quickly.
Yeah.
And not only quickly, but we owe it to them to have that clinician be the best informed with their medical history, their data, to provide the best optimal care as possible. We owed it to them, and they deserve that. And so, yeah, it kind of launched from there. We're like, well, we'll just we'll just kind of piece together like Zoom, and then we built some back end stuff where we could integrate into the medical records so that as soon as a patient called, usually with the help from a nurse, because we're integrated in their medical record popped up and a video popped up. And
Wow.
it like night and day changed the quality of the assessment for me and a patient. I could see them, I could see their medications, I could see all their issues, and then talk to the nurse and then provide feedback to them, write a note about it. Because I was able to capture all that stuff in real time, then I could bill for it.
Yeah.
And I remember we're like, man, let's roll the dice here. And we like enrolled and did all the difficulty of enrolling in insurance, which is a whole nother podcast, probably.
Yeah.
But I remember the first day we got a payment and we're like, this is working.
Let's go.
And it was really exciting that we were then able to solve those pain points of, man, I could get extra revenue for this. I provide a better care for the patient. And the patient could contact and the nurse could contact the
Yeah.
provider in real time. And we're holding strong now. Still today, we can connect them in less than a minute. So any patient in a nursing home can talk to a provider in less than a minute.
Yeah. And I think you may have said this, but how did you get your first customer again? Was it your current employer that you were working at? Or, okay,
Yeah,
perfect.
so it was
Yeah.
unique that again I had worked on the administrative side, so I had connection.
Yeah.
And then because of those connections, I worked on the clinical side, just as a just a macro level, every nursing home has to contract with a medical director, so a
Okay.
licensed doctor
Sure.
provider. Um, and those are the individuals then who are responsible for the clinical care for the patients. And I was a contractor employer with one of those medical director groups. And so I approached the guys and I was like, "Hey, I I want to do this for me." Again, I did it for me. I was like, "I'm gonna do this. I'm gonna figure it out for me." And then I was like, "Hey, this works." Like, and found out that if I approached all the other people that were on call 24/7 and hated it, I'd be like, "Hey, Christian, what's the worst part of your job?" And they'd be like, "I hate call." Well, let me just take your call for you. Like, I
Hmm.
figured out a way to get paid for it, and I can provide better care for the patient. And you know what? All in all, I won't even charge you because like I get money just from the reps. So I just want your calls and easiest sell of my life. Like it
Yeah.
wasn't really hard to like convince them like this is a good thing. And then so we started out with 2 nursing homes and grew to 7, and then over a year we doubled, we hit over 100, and now we're in 250 with, by the
Wow.
end of this year, we'll be in over 1,000 nursing homes this year.
Wow. So on that note, to transition more into the scale of Vital Care,
Yeah.
how's the transition been being the founder, CEO, leading a team for a med tech company now? I mean, walk me through that a little bit. What's
Yeah,
the
I
change been
think
like? Going from clinician to that, I'm
yeah.
sure it's quite drastic. So,
Um,
yeah.
yeah, the process was, like, really interesting just because I think as any founder, you're going in, you're, like, involved in every single aspect of the business.
Right.
Kinda unique to me in that I could bar the coding, even though AI can help me out a little bit. I could really, because of the administrative and the clinical side, I could really jump into every position in the company and had unique insight into each of those. So was able to kind of stand up those verticals in a
Yeah.
way. And then we were getting a lot of calls. I could jump in and take calls and actually the first like 3 or 4 months, I was the only clinician taking calls and we were getting
Wow.
hundreds of calls. And yeah, that was too much, but like you do what you got to do. And so really this kind of transformation then we're uh, maybe we're on to something here. Like this is like doing a really good job. Our data was showing we're providing better care for patients. We're reducing the amount of patients that were being sent to the ER. Outcomes were getting better. Nurses liked getting talking to a provider in real time rather than waiting on a text or a call back for a couple hours. Then the nursing homes liked it. Patients liked it, and really just was like, man, we have this kind of rudimentary platform that was working, but how do we scale this and how do we make it bigger? And I, because we had some revenue already coming in, um, kind of went out and was like, man, friends and family, like this could be a really big thing. Had some really close friends that, um, frankly, just kind of took a gamble and trusted me, gave me some money, and we were able to put more in a
Wow.
platform. We were able to contract more providers, and we did it in a way that also allowed for, again, that work-life balance for those clinicians. So, they're all contracted 1099 providers, and they take the calls, and they can take it from their phone. We built an app.
Wow.
They could be at a soccer game, they could be at a grocery store. And so provided their work-life balance, they make good money. And really kind of took off from there. And kind of the input, like why I'm like explaining that is because I was kind of involved in every kind of strategic part of that, letting go was like so hard. And so as we continued to grow and we got more business side of it and had to let all of the IT side go and let our now CTO, his name's Austin, he's the man. And he got some product developers. We were able to hire some offshore developers for a little bit. We have onshore developers, and AI is able to allow us to keep our team kind of small now, but like we have a product, a UX UI, and then an IT guy who helps with all the IT security stuff. I had to
Yeah.
completely let go of that. And then got lucky and hired an ops person who understood billing and hired a billing person and kind of expert in the space, and then hired more providers to help put protocols, and got a medical director and did research
Wow.
on best telehealth case medicine to help patients. And then you need a sales guy, and got sales and started going to conferences, and really had to learn to step away and let go in those areas, and focus on the things that like only I could do,
Yeah.
and help setting the vision and the strategy and getting the right people in the right seats. A
How have
lot of
you done with that transition? And I'm just curious, coming from me being a founder myself,
yeah,
it's hard to 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 be okay for me with being hands off, and the delegation often I feel guilty almost. And I don't know if that's something you've ever felt, but for me at least, I want to know what's going on in the code base. And if
yeah,
someone's developing something and I'm not fully on it, I feel like I can't speak as confidently in meetings about it. And that just feels really unnatural to me. So I'm just curious, founder to founder,
yeah.
to kind of ask you about that.
I think a couple of things. That one, it requires a little bit of humility. Like even a meeting today, like someone, it was probably one of the product team used some word, and I was like, "You guys, I have no idea what that means. Like, you got to tell
Yeah,
me." I'll Google a ton of words just to try to figure out. But also, really hiring really good people who, at certain points, had become in like chance. You got to let me do my job. Like, just like trust me. I got it. I got your back. I believe in this vision, and then really like
wow.
letting go and like I even like today, I'm like, it's fine. They'll take care of it. Don't jump in. They
Yeah,
got it. I have to like have this internal dialogue where I'm like, man, I really want them to grow and develop as people and as managers. And so, I'm not great at it. It's been really hard. I'm still in the background looking at all the weeds. So I like still look at the KPIs. I look at the calls that are coming in. I
yeah,
like spend a couple hours on maybe a consult that didn't go great and like
sure.
looking for ways to improve. But I don't necessarily then push that on like the managers. I know they're taking care of it while still me staying informed, and staying out of their operations. And maybe you should ask them. They'll have a different story for you. But yeah, it's like kind of a work in progress. And I think my one-on-ones and meetings with them are really good. We read a book as a kind of an executive team and kind of analyze where we're at as a team and how do we improve. And a lot of those are directed at me. Um,
Yeah,
but also just being humble and being like, I would tell them, I was like, you guys, this is really hard for me to let go, and I'm sorry, but I need you to be like, hey, let go. I got this. Like, trust
yeah,
me. And I promise, and that I'll come and ask you for help if I need it. And then really being okay to not know all the things, which is hard.
yeah,
Um, and being able to be humble enough to be like, man, I don't understand what you're talking about. Can you tell me like a 3-year old? Um, you don't, if you're successful, my thought process is like, just hire smart people and let them do smart things.
yeah,
And I try to live by that as much as I can. And you don't have to be the smartest person. You just have to be able to like trust the people around you. And I think if we're doing it right, we're hopefully hiring smarter people than us to do those things. So I don't know.
yeah.
It's a work in progress. Working on it.
I feel it.
But I have found that the more I let go, the more that they're able to then multiply, be a multiplier in that space because they're focusing on it, they're living it, and they're searching for solutions, and they're doing more with it than I could have ever done. And so now we
Amazing.
have a team of over 30 full-time staff, and we have over 150 contracted providers across the country.
Wow.
There's no way I could do it myself, and that realization comes quick and it comes hard, but
Yeah, incredible. And really well said. And I'll probably take a lot of that to heart as well
well,
as I'm in my
well, good
scaling
luck.
journey.
Yeah,
Yeah.
I'm not
Yeah.
perfect at it, but
It's no, I
like
don't.
everyone,
Yeah.
we're trying to get better.
Yeah. Yeah. No, that's awesome. Um, so as far as, we're kind of coming up on time here, but we can go a couple more minutes. I'm just curious to learn maybe about how you guys are kind of leveraging AI right now with Vital Care, because I know like on your website there's some functional pieces where you guys have AI, and I'd just be curious to kind of get your thoughts on like maybe just one use case where AI is helping either the customer or patient or your team.
Yeah, I think the world of AI has just opened up so many things. And even in the last 6 months, just like leaps and bounds of like capabilities. Our AI philosophies may be a little bit different in that we're not looking for AI work efficiency models. So a lot of people are tackling those. And we do implement those, but kind of outsource vendor those where we do third party platform AI billing, coding stuff. We also have
Yeah.
some ambient listening that helps scribe for our providers. So it's writing their notes and capturing the right things, and then kind of AI support function on the back to make sure we're not overbilling, but we're also not underbilling, and we're appropriately capturing the revenue that we're owed and the work that we're doing. But really, our focus is like, how do we leverage AI for better patient outcomes? And that's always our biggest patient. That's our biggest driver here. And I think there's a lot of long ways for AI to go right now to kind of get this right, just because AI implementation in a low impact setting for a med tech company um, could be easy as like, oh man, we don't have any engineers and we just have AI kind of doing all these spot checks, testing and coding and UX, UI, bucketing and all the dark web like stuff that everyone talks about. And that's okay on like low impact stuff. But we're like talking about real people, like real people's lives, medications that could impact and ultimately be harmful for a patient. So,
Yeah.
um, there's our really goal is like, because we're sitting on all this information. So now we have hundreds of thousands of like patient interactions and calls. We have this unique data. Again, in a situation where data is so siloed because of all these nursing homes
Yeah.
and highly complex patients. So if you think about like the LLM large data groups, they're pulling all that information from the coasts or large health systems. But uniquely, a large part of healthcare and healthcare costs sits in the space that we're operating.
Wow.
And most people don't have unique access to that
Yeah.
because those medical records are so siloed and kind of surface to the top. We're like, hey, wait, we are like integrating into all these siloed medical record systems. We're sitting on kind of this unique set of data
Yeah.
um, now that we could be looking at this data where I can pull uh, a patient call comes in, a provider's talking to a patient and talking to the nurse because I've pulled all of their medical records, excuse me. I have a lot of data about them. I then can leverage AI to help me in that decision process. So it knows that they have congestive heart failure. It knows they have diabetes. They have high blood pressure, all of those things. And it knows the trend from the last couple of years.
Yeah.
It knows all the medications they're on so that in real time, it's listening to a provider talk to the patient. It's like aggregating all of that information and then posing well, these are like the 5 top likely diagnosis or problems that are happening with this patient now, and then we can click into that and it because of AI and support, and then adding that to a clinician, they can make the best decision for that patient, even to the point where then we're moving into proactive care. So most of healthcare right now is reactive care. There's big pushes for like population health and like preventative medicine. Still is not a great thing in America yet. And so we can now have a unique position where I can predict if a patient's going to be going back to the hospital in the next 5 days unless we do these things. And so ultimately, we're helping do proactive preventative care on these patients and getting them the help that they need in an environment that maybe they didn't have access to before because of
Yeah.
margins or costs, and they just didn't have a lot of money to invest in tech. Now we're uniquely positioned to be able to provide that information to inform best care medicine, evidence based medicine, and also feed that back to insurance companies and say, hey, these are the things we could be doing. If we're preventing them from the hospital, this is how much money we're saving. So now we have insurance companies that are uniquely interested in the work we're doing because we're also proving out models and doing proactive care and
Wow.
preventative medicine, which is ultimately a better place to operate from a clinical standpoint is like, I don't want to be in a position where now I'm like forcing my hand and they're really sick and there's bad outcomes. Like I can then put stuff in place before they get there. And so that's what we're putting all of our efforts and our money into is we're going to capitalize on the people that are doing great work on workflow efficiency stuff. And there's a lot of them. But we're putting all of our efforts in unique position and data to help with patient outcomes. So we're
Patient
really excited
outcomes.
about it.
Wow.
Yeah.
Yeah. That's super, super exciting. And the phrase that I keep hearing is data is becoming the main moat in the age of AI when SaaS is commoditized now.
Yeah.
It's really the data that you are operating in. And in healthcare, I guess luckily for us, with how
Yeah.
compliant you have to be and how sensitive it is, if you're in there and you're working with skilled nursing facilities and not many people are looking at that kind of data,
Yeah.
it's a huge
Well,
competitive
yeah, and I
advantage.
think even next level there, we're really excited. We're launching some partnerships with large health systems because when those nursing home patients do go back to the
Hmm.
hospital doesn't know who they are. That
Wow.
patient doesn't know why they're there. The ER doctor doesn't know why they're there. That poor EMS person that transports has no clue why they're there. And so you do these $1 million workups on these patients, but because of our kind of aggregate siloed positioning in our platform, because we can take all that data,
Yeah,
we then can integrate into large health systems and share that data with them in real time and say, hey, this is why the patient's coming, this is what they need, this is their history, this is their background. It
incredible.
gets them moving through the health system quicker. They're staying in a ER less amount of time.
Yeah,
So about 3 times um, an average like nursing home patient takes about 3 times as much time in a hospital bed,
okay.
in ER bed for a workup, and so they're missing out on 3 additional patients. The waiting rooms are long. Everyone's backed up. The whole system's backed up. But ultimately, if they have the right information, they have the communication with the nursing home. A lot of those patients can just come back to the nursing home rather than getting admitted to the hospital. And
Wow.
so we're also then impacting this readmission rate back to the hospital. And ultimately, because of the comorbidities and the bugs and the germs, the viruses that are at a hospital, that's not the best place for these patients to be anyways. Their immune systems are low. It's not their home. They already have some like made dementia or struggle in new environments. And so getting them back to what is their home is actually the best thing for them. So what
Yeah,
ultimately started out as like a, a really non-altruistic way of like trying to figure out a problem really then is fun for me to connect as a business person because all those metrics that I'm worried about, KPIs that I'm worried about every single day, those are people. That person that we prevented from an AR visit or we got a new consultation. Those are real people. Those are people
yeah,
with who have spouses and daughters and kids and grandkids and friends and people that love them. All of those metrics that a lot of businesses are always chasing is really fun for me to be able to like then equate that for a humanity perspective because those numbers are people and that's what it's all
yeah,
about. And that's why people work in healthcare despite it being so difficult is like those
yeah.
are real people and we're making a real difference. So
Incredible. I have nothing more to add. One of the most like pragmatic and tangible use cases for data with patient outcomes. So I really, really appreciate that. I think it gives me like a much clearer picture as far as how telehealth really can impact patients. So
yeah.
this is an awesome conversation, Chance.
No, yeah,
And I hope
thanks
the
for having
listeners
me.
think the same because they should.
Thanks for being persistent. Sorry, it's been kind of
Yeah.
crazy and
Yeah, man.
been a
No,
crazy year, but really fun and have a really great team and props go to all of them who are living
it's
this and
awesome.
working on this day to day. So yeah, it's been
Yeah.
fun. Great to chat with you today.
Awesome. Yeah. Ladies and gentlemen, this is another episode of the Healthcare Growth Cycle podcast. We will see you next month. Thank you.
Awesome. Thanks, Christian.